Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm a passionate pharmacist here to bring you quality information regarding medications and health-related topics, and in the process, expand my own knowledge. So let's begin with today's video. Contrave is a combination of two drug classes consisting of bupropion, which is a norepinephrine dopamine reuptake inhibitor, and naltrexone, which is an opioid receptor antagonist. Bupropion and its major metabolite, hydroxybupropion, are weak dopamine transporter inhibitors and moderate norepinephrine transporter inhibitors. It has a higher affinity for norepinephrine transporter than it does dopamine transporter. Of course, in this video, I'll focus on how bupropion promotes weight loss. Bupropion affects appetite regulation via the hypothalamus, and it also increases energy expenditure. If you watch my obesity video number 2, then you might recall that the arcuate nucleus contains a Goody-related peptide, neuropeptide Y neurons that stimulate appetite, and POMC neurons that suppress appetite, and both opposing neuron pathways converge at melanocortin-4 receptors in the paraventricular nucleus. Bupropion indirectly increases POMC neuron firing by altering catecholamine levels, which stimulates intracellular processing of pro-opiomelanocortin, which is a large precursor protein. This protein is eventually converted into smaller peptides, which are alpha melanocyte stimulating hormone and beta endorphin. Alpha melanocyte stimulating hormone will then go on to activate melanocortin-4 receptors in the paraventricular nucleus, leading to appetite suppression. Bupropion also showed increased energy expenditure in preclinical studies with mice via increased temperature and activity levels. Now let's look at why bupropion is paired with naltrexone. Beta endorphin will activate opioid receptors on POMC neurons, creating a negative feedback loop. Naltrexone will block the opioid receptors, allowing POMC neurons to be active for a longer period of time. Contrave produces a weight loss of approximately 5 to 6% at the 1-year mark. The most common adverse effect is mild transient nausea. It can also cause constipation, vomiting, headaches, and insomnia. Its contraindications include chronic opioid use, uncontrolled hypertension, seizure disorders, patients who are in the process of discontinuing either alcohol, benzodiazepines, or barbiturates, and patients on MAOIs. Its warnings include a U.S. box warning for suicidality, accidental opioid overdose, cardiovascular effects, hepatotoxicity, psychiatric effects, ocular effects, and seizures. It's approved for chronic weight management. Contrave is a 12-hour tablet consisting of 8 milligrams of naltrexone and 90 milligrams of bupropion. The starting dose is 1 tablet by mouth once a day in the morning for 1 week. Increase if tolerated by 1 tablet by mouth twice a day for 1 week. Again, if tolerated, increase to 2 tablets by mouth in the morning and 1 tablet in the evening for 1 week. And finally, 2 tablets by mouth twice a day. If weight loss is less than 4 to 5% after 3 months, consider discontinuing the medication. LexiDrug states patients with moderate to severe renal impairment, the dose should not exceed 1 tablet by mouth twice a day, and it states that end-stage renal disease use is not recommended. If you're asking yourself what is considered moderate renal impairment, it can be defined as an estimated glomerular filtration rate of less than 60 milliliters per minute. Patients with moderate hepatic impairment, the dose should also be limited to 1 tablet by mouth twice a day. This would be patients with a Child-Pugh Class B. It's not approved for the use in patients under the age of 18. Bupropion's drug interactions include medications that are CYP2D6 substrates, the use of MAOIs, ethyl alcohol, bremelanotide, and opioid agonists. Naltrexone and bupropion likely produce a synergistic or additive effect on the nausea pathways. Naltrexone blocks mu-opioid receptors in the chemoreceptor trigger zone and the gastrointestinal tract, which can trigger nausea and vomiting, while bupropion's dopaminergic activity in the chemoreceptor trigger zone is a well-established trigger for nausea. Nausea occurs in 32.5% of Contrave-treated patients versus 6.7% on placebo, nearly a 5-fold difference. Most patients do not experience persistent nausea with continued use. Chronic opioid use is an absolute contraindication to Contrave. Naltrexone antagonizes all opioid effects, preventing pain relief and precipitating opioid withdrawal. It's recommended to have patients be opioid-free for 7 to 10 days for most short-acting opioids. For opioid-naive patients who require opioid treatment, Contrave should be temporarily discontinued. Contrave causes small but statistically significant increases in systolic blood pressure and diastolic blood pressure, along with increases in the resting heart rate as well. This is why it's contraindicated in uncontrolled hypertension. Blood pressure increases may be greater in Contrave versus bupropion use alone. The American Gastroenterological Association Guideline on Pharmacological Interventions for Adults with Obesity recommends that all patients on Contrave have their vital signs monitored. Unlike orlistat and fusemia, which reduce blood pressure in hypertension patients after 6 to 13 months of treatment, Contrave showed no difference in systolic or diastolic blood pressure changes compared to placebo in a large trial of over 8,000 participants with hypertension. The same trial found no difference in all-cause mortality, cardiovascular mortality, major cardiovascular events, or serious adverse events between Contrave and placebo after 2 years, but the incidence of overall adverse events was significantly higher with Contrave. Contrave is contraindicated in patients with seizure disorders, also for patients undergoing abrupt discontinuation of alcohol, benzodiazepines, barbiturates, and patients on anti-epileptic drugs, or patients with a history of anorexia nervosa or bulimia because the seizure risk is elevated in these scenarios, and bupropion can lower the seizure threshold. Several mechanisms likely contribute to bupropion seizure risk, but excessive dopaminergic and noradrenergic activity can enhance neuronal excitability and reduce the threshold for seizure generation. If a seizure does occur, Contrave should be discontinued indefinitely. Contrave carries an FDA-mandated box warning for increased risk of suicidal thoughts and behavior, based on data from antidepressant trials showing this risk in children and adolescents and young adults, though the actual incidence in Contrave obesity trials was 0. The pooled analysis of 5 randomized controlled trials involving over 4,000 adults with obesity provides reassuring real-world evidence that Contrave was not associated with suicidal ideation or behavior in this patient population. The box warning derived from pediatric and young adult antidepressant trials may overestimate the actual suicide risk in the approved Contrave patient population. Because the box warning remains in effect, it is still essential for pharmacists to counsel patients on the risk for suicidal ideations for patients using Contrave. Patients on Contrave are at an increased risk for opioid overdose, and you may be asking yourself why. The first reason stems from attempts to overcome naltrexone's opioid blockade by patients taking larger doses of opioids. This occurs because once naltrexone dissociates from its receptors, these high circulating opioid concentrations can cause rapid onset respiratory depression and overdose. Contrave can also make patients more sensitive to opioids when treatment is discontinued or temporarily interrupted, even when lower doses of opioids are used. This occurs because the body downregulates neuroadaptations that were once present with regular opioid receptor activation, that once normally protected against opioid-induced respiratory depression and sedation. The most common psychiatric adverse effects occur during dose escalation and are generally mild. Sleep disorders were the most common psychiatric adverse event at 12.7% versus 7.9% for placebo, followed by anxiety, which was 5.4% for Contrave versus 3.3% for placebo. Patients should be counseled not to take the medication with high-fat meals. When Contrave was administered with a high-fat meal in single-dose studies, naltrexone's AUC increased over 2-fold and its Cmax value increased over 3-fold, while bupropion's AUC increased 1.4-fold and its Cmax increased by 1.8. This recommendation is listed as a key strategy for minimizing seizure risk. Although the FDA labeling does not specify what a high-fat meal is, it can be defined as a meal containing 40 to 50 grams of fat or more. Bupropion and its metabolites act as CYP2D6 inhibitors. This inhibition is mediated via two mechanisms, number one being reversible enzyme inhibition, and the second method is downregulation of CYP2D6 mRNA expression in hepatocytes. As an example, during clinical studies, when a 50 mg dose of metoprolol was co-administered with Contrave's max daily dose, there was about a four-fold increase in its AUC and a two-fold increase in its Cmax value. This represents a clinically significant level of inhibition, and the FDA recommends starting CYP2D6 substrates at lower doses for patients on Contrave. Bremelanotide is listed as a major interaction with naltrexone, and this is based off of a pharmacokinetic study in which naltrexone's AUC and Cmax was decreased by 40% and 60% respectively. This is believed to be due to slowed gastric emptying caused by bremelanotide. In the case of patients receiving concurrent bremelanotide and Contrave, monitoring of weight loss becomes important. But if we were using naltrexone, say for opioid use disorder or alcohol use disorder, then this combination should be avoided. Opioid withdrawal can occur if Contrave is given to a patient currently using opioids, which is why this is a contraindication. At least 7 to 10 days should pass after opioid use before starting Contrave, and up to 2 weeks for opioids which have a longer half-life, such as buprenorphine and methadone. Patients should be counseled to minimize or avoid alcohol for two reasons. Bupropion decreases alcohol tolerance, and it increases the risk for seizures. Just like last time, I've asked ChatGPT to generate some questions for me. These questions are not designed to be necessarily really hard, but just to help you apply the information and help it stick. All right, so starting off with question number 1. A 44-year-old woman with a BMI of 37 with hypertension controlled on lisinopril 20 mg daily and metoprolol tartrate 50 mg twice a day is started on Contrave. 2 weeks after reaching the target dose of 2 tablets by mouth twice a day, she reports fatigue and lightheadedness. Her clinic blood pressure is 106/62 and her heart rate is 52. Her baseline is normally 128/78 and her heart rate 74. Which mechanism most likely explains her new symptoms? The answer is Charlie, C. A 51-year-old woman with a BMI of 39 with Child-Pugh B cirrhosis from non-alcoholic steatohepatitis is interested in Contrave. She has no history of seizures or opioid use, and her blood pressure is 126/78. Which is the most appropriate initial plan? The answer is Charlie. A 36-year-old woman with obesity, generalized anxiety disorder, and a history of bulimia nervosa with no purging episodes in the last 3 years wants Contrave to jumpstart weight loss. She drinks 1 to 2 glasses of wine on weekends and takes escitalopram 20 mg daily. Which factor is the strongest reason to avoid Contrave in this patient? The answer is alpha. A 49-year-old man with opioid use disorder maintained on methadone 80 mg daily is referred for obesity management with a BMI of 38. He wants Contrave because naltrexone helps with cravings. Which is the best recommendation? The answer is delta. A 42-year-old woman with obesity and controlled hypertension starts Contrave. After reaching 2 tablets by mouth twice a day, she reports persistent nausea and poor adherence. You suspect that both components of Contrave contribute. Which statement best describes the mechanistic basis for this effect? The answer is Bravo. A 55-year-old woman with a BMI of 36, an eGFR of 32, and no history of diabetes has been on Contrave, titrated to 2 tablets by mouth twice a day for 16 weeks. She's been on the max dose for 12 weeks already. She has lost 3% of her baseline body weight. Her blood pressure is 124/80. Her heart rate is 78. She asks whether she should continue therapy. Which is the most evidence-aligned recommendation? The answer is Bravo. A 46-year-old woman with obesity, migraine, and chronic low back pain is taking topiramate 100 mg BID, sumatriptan is needed, and metoprolol 50 mg daily. She has no history of seizures, psychiatric hospitalization, or substance use. She quit oxycodone 5 mg every 6 hours as needed 5 days ago after a short postoperative course. She is eager to start Contrave today. Which is the best plan? The answer is Bravo. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. It would mean a great deal to me. Also, I would like some feedback. Do you guys like the way I'm presenting the information? Is it clear? Do you feel like you're learning at the end of my videos? Either way, thank you and have a great day.